evening, everyone. Thank you so much to those who are waiting as we were just getting set up, making sure everything was working for you this evening. And welcome, Dr. Tsakos. Thank you so much for joining me as we're going to be talking a lot about fertility care in Greece. And I wanted to say a brief thank you to IVF Answers and the European Fertility Society for making these events possible, because I know that many people have reported back to me how much they've learned from them. And if you have any questions, feel free to put them in the question box. That does tend to fill up quite quickly, so be sure to pop those in and we'll do our best to get to as many questions as we can during the event. And so what I'd like to start with, maybe if it's okay, is a brief introduction about your history and what brings you to this work, what makes you love working in the area of fertility, and also what you think about the fertility industry in Greece as a whole, because I know many people, certainly from Ireland, UK, might not be as familiar with fertility treatment in Greece.
Sure, yeah. Hi, good evening, everyone. Thank you, Jessie. Thank you for the introduction. Well, brief history. I started off as a surgeon in my training years in England in the 90s. And during that time, we were still doing IVF via laparoscopy. So we used to retrieve the eggs abdominally. I was doing the technical part. And then, of course, I was drawn into the science and the magic of the IVF world. I was very fortunate because I worked alongside some giants of IVF, the late Professor Hull in Bristol, and Peter Wardle, also, who is still a very good friend, and we work together sometimes. And then I moved on to East Anglia, Norwich, Cambridge rotation, and I had the privilege of working with many people who had been associated with the first IVF clinic in Bourne Hall. And it's a magical world, and I was very privileged to stay in this world for very near 10 years in my time in England. When I was looking to further my career, at the time there was very few places in England where you could subspecialize in the mid-90s. And again, I was very fortunate to be the first IVF fellow of Professor Alison Murdoch up in Newcastle in the Centre for Life. And I experienced firsthand the pioneering work in mitochondrial transplantation, mitochondrial techniques and all that. And of course, I met the most amazing people from England and all over the world during my time. And then when I returned back to Greece, Greece was already on the start of very good things in IVF, because there was some amazing embryologists who came from the UK. And in particular, there was some amazing scientists who set up IVF units, Giles Palmer and Steve Davis. They're still around. Giles is back in the UK, Steve is still in Greece. So they set the pace and the history started. And that was in the mid to late 90s for Greece. Now, from then on, of course, a lot of things changed. Greece has at the moment about 40 IVF clinics. I would say that the vast majority, if not all of them, they're of exceptional quality. Most, if not all, of the medical directors are trained abroad, not in Greece. Greece doesn't have an official training program in fertility just up to now. So most of them were trained abroad, and most of them in the UK, but of course some very good colleagues in other countries like Germany, Australia, and so forth. So there's very good level of service, very good practice. Very strict regulation. I mean, most people believe that Greece is very liberal and everything is possible. No, I think this is the US, not Greece. Greece is very highly regulated. The regulation authority is there, has been in place for many years. And, there's a lot of bureaucracy, there's a lot of work, and it's becoming more and more complex, as it is everywhere in the world. The major turning point, and which is relevant to our patients all over the world, was the Greek crisis, the financial crisis, which started to appear, I would say, in 2010. So this is the time where, up until then, we were very happy working with local patients and all that. But after that, many IVF clinics, including Embryoclinic, we had to look abroad to attract patients for obvious reasons, because of the crisis, because of the immigration. There was about 500,000 Greeks, young Greeks, who immigrated to foreign countries and so forth. So in order to sustain our clinics, we had to look abroad. And of course, that created what I call a very positive and a very productive competition. We're all good friends between us. We speak to each other. We refer patients to each other. We ask questions to each other. I think the climate overall in Greece is amazing. Most, I have to say, I'm from the UK, so most of them are the people I trained with in the 90s. So, it's a very friendly environment. So this is the story of IVF in Greece. At the moment, I believe that Greece, although it started attracting patients well after Spain and well after the Czech Republic, but I believe in Europe, it's probably now perhaps in the top 3 fertility destinations.
Yeah, I would certainly say so from what I've seen with my clients, as I've had many people over the years going to Greece and continue to do so. Even right back in, I'd say, maybe 2017, when I was starting to come across the research myself about PRP, which I definitely want to talk to you about, platelet-reduced plasma or ovarian rejuvenation, which I know people are more familiar with now. But back then, it really did seem that Greece were amongst the pioneers in that. And there was, I know, another doctor in California who was doing that. So if you could maybe explain a bit more about that topic to people, because I know it started out as something that was considered very, far-fetched, and many didn't understand it or know about it. But now it seems to be much more standardized within the industry.
Well, yeah, I mean, I agree with you. However, I still think that there's a long way to go.
Yeah.
I think we're still in the preliminary days of PRP, especially for fertility, perhaps for facial rejuvenation and for orthopedics, it's a little bit more standardized. The fertility target organs, and mainly the ovaries, but also the endometrium, are a little bit more complex organs. So I believe the science is now starting to emerge. There's no overwhelming science. I think, we all know too well that there's a lot of opposition to PRP, a lot of controversy. I think we're getting there, but we're not there yet. I mean, that's my overall approach. Sadly, there isn't really very strong evidence to support its use generally. We haven't been able to identify exactly the protocols, exactly the indications, the patients who would benefit the most, even the technique of obtaining the PRP, whether we should be heating it or not, whether we should be activating it or not, and so forth. I think, like most technologies in medicine, they have been applied well before the evidence was there. And, as you said, there were some pioneers who believed very strongly. So I think we're not there yet. I believe overall that endometrial PRP has a place. In my experience, in my opinion, and looking into the studies and the meta-analysis, the studies of the studies, there seems to be fair evidence for treating endometrial conditions to a certain extent. Of course, it's not a panacea. It's not the absolute treatment with 100% success. Myself, my team, and I think many of us, many of our colleagues are a little bit guarded regarding ovarian PRP. I think that the problem has been that there hasn't been very good studies. There's no real perspective randomized studies. I accept that there may be complex to be designed and executed and all that. So I think endometrial PRP probably yes. Ovarian PRP maybe. That's my approach.
Okay, and given that it's obviously offered at your clinic, and just explain to people the difference between ovarian and endometrial PRP, but because they might be a bit lost as to the difference between the two, but what would be the indications where you would be a maybe for recommending ovarian PRP and versus for the endometrial PRP?
Sure. For endometrial PRP, I think it's straightforward. And in fact, even the European Society of Human Reproduction, ESHRE, they have introduced a workshop on endometrial PRP 2 years ago. which many of us attended, including myself. So basically, the endometrium is the organ of the inside, the lining of the internal lining of the uterus, which may be affected either visibly or non-visibly. So a very clear injury to the endometrium is produced by either a DNC or a miscarriage or a medically managed miscarriage or a polyp resection or diaphragm resection or infection of unknown origin. So if there's any suspicion of damage of the endometrium, any consequence of either surgery or a failed pregnancy, then based on the hysteroscopy assessment and also on the ultrasound scan assessment, we can treat that uterine factor infertility by PRP instillation, either flushing or injection into the endometrium. Now, the evidence, there's pretty good evidence. To be honest, I'm convinced. I'm happy with the data, and also I'm happy with the outcomes we've had with our patients over the last few years. We've only been using it for about 3 years now. It took us more than 10 years studying all the various protocols and the research projects in order to identify and produce our own protocols. So that's for endometrial PRP. Also, endometrial PRP may be indicated for cases of thin endometrium, where this is a very common occurrence for many of our patients, despite good doses of estrogen or FSH, and the endometrium doesn't grow. This usually has to do with some sort of scarring in the endometrium. So PRP may be indicated there in order to produce better results. So that's the endometrial PRP. Now, ovarian PRP, the ambition, the scientific hypothesis, if you like, is much more ambitious, because we hypothesize that by injecting this activating substance, this substance that can create blood vessels, that can create new tissue, we hope and we hypothesize that may produce better follicles and better eggs. I think this is where perhaps we don't get it right, because yes, we can probably proliferate, we can probably improve the quality of the tissue there, the quality of the stroma of the ovaries, the quality of the vessels, but oocyte production is much more complex, much more genetically determined, and much more difficult to be achieved. So I think here we have to be honest with our patients. We have to explain to them that the evidence is not overwhelming. That the way I do it is that I have a very, very long information and consent form, explaining the data, explaining the research evidence to date, explaining the diversity of patients that have been published, and the results and the techniques and the methods and the protocols. It's all pretty chaotic, I have to say. And also explain to them that we cannot guarantee the result. I try to be sensible. I try to have sensible expectations as a scientist, but also as a clinician with my patients. For example, I would never promise to a 45-year-old that she would produce healthy eggs, because we all know too well that the genetic predisposition is there, and the age factor, which affects the euploidy of the eggs, cannot be altered by anything, as far as I'm aware. So we have to be very very careful. I think one of the problems,
not give false hope.
Yeah, we don't want to give false hope. I mean, in my opinion, a younger patient is probably a better candidate. A younger patient, perhaps with a history of ovarian surgery, of endometriosis, where I don't have huge worry about the genetic component of those eggs, and it's probably a matter of the environment being helped. And this is where I would probably place my bets that perhaps in the future PRP will show its benefit.
Would be beneficial. So would that include a younger woman, but who is showing signs of premature ovarian insufficiency?
Yes.
It would. Okay, that's interesting.
Also, for example, we're under a lot of pressure, Jessica, to perform. I mean, our patients, they are very well read. They trust us. They trust science. They have access to ChatGPT. And we're under a lot of pressure to perform treatments that are not proven yet. I think this is one of the biggest challenges we face every day, the pressure from our patients. And sometimes also the pressure from the managers, if you understand.
Yeah, I do.
We're very happy because we don't have managers. We are doctors. So it's just a matter of medical science and ethics, and
which is how it should be.
Yeah, and most of our patients, they seem to understand, our reservation. I mean, it is, in my opinion, PRP is probably the last resort before egg donation. That's how I see it.
Yes, that's what I would have seen with clients as well. Certainly anecdotally, I have seen people who benefited from it. In other words, people who weren't getting embryos and then they did, or were getting better quality ones or saw success. But equally, I'd say 50-50 with what I've seen anyway, that there are those who then it does nothing for them. I mean, it's, I suppose, neutral in the sense that it's obviously not a medication, so they're not having damage done to them in that sense, potentially. But yes, I would agree that there's definitely a lot that needs to be done in that area and more that needs to be looked into. Sure. I'll get to the questions there in a second.
Sorry to interrupt, Jessica. If I could add just a couple of points. I mean, to be honest, I feel much more confident when I do PRP, ovarian PRP laparoscopically.
Yes.
And I feel confident because the injection can be much more accurate. It can be ensured that it's going in the right place, because many of those women, they have tiny ovaries, and many of them of very difficult access. So to do it vaginally. So I generally, and our results we haven't published yet, but they seem to be better. They seem to be doing better with laparoscopy. Of course, it's more interventional procedure than the transvaginal. And also at the same time with laparoscopy, we exclude conditions like endometriosis, or we treat.
I was just going to ask, could you do that together? Yeah, that's brilliant. Okay.
Which may help a great deal. So we kill two birds with one stone, and occasionally we identify other factors like serious tubal factor, serious pelvic infection that has been missed by scans or by other tests. So let's not forget that perhaps PRP in the context of a laparoscopy may have a little bit more sense. It makes more sense. Since we're there, we do the diagnostic laparoscopy, we do the dye, we check the tubes, we do hysteroscopy, take a small biopsy from the uterus, from the endometrium to ensure there's no simple stuff, endometritis or infection or abnormal microbes. And then, since we're there, we just inject a little bit of PRP if there's an infection.
Like the triple whammy. You're hitting three at once. Which, let's talk about that, because obviously with your surgical background, and I know that certainly anybody who's been following the news in Ireland of late knows that we have a pretty major problem with our level of care that is on offer for those with a history of endometriosis. And as I've seen with plenty of my clients, unfortunately, silent endometriosis is extremely common and something that isn't discussed, isn't acknowledged, and obviously requires proper surgical care and understanding. So could you talk a bit more about that and what you've seen in your practice and the importance of it for people? Because I've certainly seen it make or break people's pregnancy success.
Sure. Of course, yeah, thank you very much. I will go back in history a little bit. I mean, in the 90s, no one, at least in England where I was training, no one would go through IVF without having had at least laparoscopy and hysteroscopy at least once. I think that was a little bit over the top at the time. Now we see that only the minority of IVF patients, they've had hysteroscopy and laparoscopy, which I think is the other wrong end of the spectrum. So that's one observation. The second observation is that in my times, in the 90s, perhaps in the early 2000s, the training of a fertility specialist included training in endoscopy. Now we see more often that this is not the case. So the new generation, with all due respect to my amazing new colleagues, they're not trained in surgical fertility treatment, not even diagnosis. So if you're not a hammer, you don't see nails.
Yes.
So if you're not trained, if you haven't done laparoscopies, if you haven't pinched yourself many times, arguing with your radiology colleagues, how did they miss on MRI stage 4 endometriosis and so forth, you don't realize how common it is and how detrimental it may be. So I think there's a big gap here, Jessica, and I have to address that. Unfortunately, the new generation of fertility specialists, they only see IVF.
Yes.
In my strong opinion and experience of 35 years now, is that this is wrong. I think we're not doing justice to our patients. We satisfy our patients. They come, they want to do IVF tomorrow. I mean, today I was arguing with a patient on the phone who couldn't stand the 3 to 4 month waiting list for egg donation, but this is a fact. And it's, we try to offer the best possible treatment, but sometimes the best possible treatment is bypassing and cutting corners, which is not for the absolute benefit of the patients. I see many times, I would say weekly, cases with serious issues, anatomical issues, abnormal uterus with adenomyosis, with polyps, diaphragms, with hydrosalpinges, who've had half a dozen of failed IVFs or miscarriages. So I think we have to meet in the middle. I think units and departments, fertility departments, they have to attract some expertise in surgery. They don't have to be in one person, but I think they have to work very closely together. Equally, the surgical colleagues, and as most people know only too well, that's my main background and my passion, if you like, because if you can fix something surgically, you don't fix it for once, you fix it for a lifetime. In terms of fertility, the overall chance of having 1, 2, 3 children is much higher than giving them a top IVF treatment. So please don't remember that. It improves the background fecundity by many times. But even surgical colleagues, I mean, I discuss with endometriosis centers of excellence, very few, if any, they have fertility specialists sitting on the board. So I think we need to communicate a little bit more, a little bit better together.
I concur completely, and I think you've explained something which I haven't really heard said by other consultants that I've spoken to, this chasm that there is between the fertility clinics and often, people off somewhere else seeing a gynae who's very much focused on the anatomical side saying, sure, for goodness sake, why didn't the clinic send you to me first? Based on your history, particularly for unexplained infertility or trying over a year and everything else is looking good, seemingly, because I've certainly seen it over the last 20 years, many cases where it genuinely made the difference between their success or not. Sometimes cases where they went on to conceive non-assisted, 3 to 4 months later post laparoscopy, versus those then obviously seeing better outcomes with egg quality, implantation, and lower miscarriage risk. So on that note, because of what I was saying, the issues are here in Ireland in particular, with the level of care, what would you deem then, with your history and background, the gold standard, and explaining the difference between excision and ablation, and spotting endo deposits, looking properly for them, because I think that's something that is a source of confusion for people.
Sure. If I were to explain everything in 1 minute, I would say that endometriosis is probably the most challenging disease overall. Because it has many faces, many presentations, many manifestations. It can change behavior over the years and all that. And the most important is diagnosis. I think where we're failing our patients is in the diagnosis. And that has to be done before the decision for surgery. More often than not, we get that wrong. We see an ovarian cyst and endometrioma, and we miss deep endometriosis, which may not be evident even on laparoscopy if we don't look carefully and all that. So I think we have to have high level of suspicion. We need to understand that unexplained infertility is probably associated with endometriosis is in 1 in 3 or even 50% of cases. I think we need to offer to our patients thorough imaging by means of, I prefer high resolution 3D, 4D ultrasound. I believe that most evidence now is there. Not because the technology is so much better than the MRI, but I think that people are a little bit more skilled users of that technology. And our MRI colleagues, unless they're highly specialized in looking for endometriosis, they're going to miss it. They're going to miss it. So pre-operative diagnosis is very important. And then when it comes to surgery, it can be very complex surgery. I believe endometriosis surgery is by far the most complex surgery we can do. I think the only other comparison is ovarian cancer debulking, which we don't see it. We don't do very often these days. It's challenging also because not only do we want size, by all means excision is the gold standard, but also we want to retain the functionality and the viewpoint, the way a fertility surgeon looks at an ovarian cyst is totally different to the way, for example, a cancer surgeon looks at an ovarian cyst. If we change the way we look at things, the things we look at change. I mean, this cannot be more correct than that. So it can be challenging. In my opinion, again, it's very important to counsel the patients thoroughly. I mean, preoperative counseling and consultation may take easily 2 hours. What are we going to do? I mean, of course, there are some very aggressive surgeons who, for example, remove part of the bowel easier than others. But is this for the benefit of the patient? I'm not 100% convinced, especially when there may be alternatives. And what do we do if we find this unsuspectedly? We haven't diagnosed preoperatively major bowel endometriosis. So, are we going to go and perform major complicated surgery, or are we going to allow a patient second look and all that? So endometriosis is very, very complex. I think we need to keep talking with each other. Thankfully, in Europe, there's a group of specialists who communicate with each other, and we're very happy with the occasional help from some US surgeons who participate in our meetings and all that. But it's becoming more and more challenging. But I would say diagnosis, correct diagnosis, second opinion diagnosis. For example, in my department, we bring in a specialist from Germany occasionally for the very challenging cases. We'd rather delay surgery for a month or two rather than be surprised by unexpected diagnosis intraoperatively.
I think that's very wise and exactly what I'd like to hear, because what you touched on there, the importance of informed consent for people really understanding what they're getting themselves in for, and that deeper discussion, if it's a complex case, do they require, the attendance of a gastroenterologist at the same time, or a urologist if there's the bladder involvement, and also what you were saying just about the industry as a whole. Proper communication, discussing the research, and making sure that there's some level of standardization of care, because I think that that's something that appears to be missing at the moment. It's very disconcerting when you hear people saying that they're speaking to one practitioner and hearing one thing and then hearing something entirely different elsewhere. So would you have any advice to people about what they should be asking in terms of questions to gauge whether they are working with the right consultant or not when it comes to addressing their concerns about endometriosis, or indeed any other surgical issues such as uterine anomalies that need to be addressed?
Sure. I believe number one is a very specialized center. And now we're coming down to the technology. In that center, there must be a multidisciplinary team involving gynae surgeons, benign surgeons, experienced fertility surgeons, high technology. I think laparoscopy is not enough in our times, although the evidence is not quite there yet, but it's coming. I think robotic surgery will eventually replace a conventional laparoscopy for endometriosis management. There's no comparison. As a laparoscopic surgeon of 35 years, there's no comparison. I challenge any of the laparoscopic surgeons, any of the patients, any of the colleagues, to do at the same time, same surgeon, same procedure, robotically or laparoscopically, and then watch the video. It's like having a novice and an expert operating. I think robotic surgery, by definition, robotic technology has to be incorporated into a highly advanced endometriosis center. It goes without saying. Many advanced senior endometriosis surgeons, they don't do laparoscopy at all, and I can see where they're coming from. I probably agree with them. The problem is, of course, what do we do with unsuspected endometriosis when we go in for something very simple and then we find stage 4 endometriosis? Again, that can be challenging. It's very complex. So multidisciplinary team, advanced technology, advanced imaging, including 3D, 4D ultrasound, together with MRI scanning, fertility counseling, occasional discussions for fertility preservation before or after surgery, and of course look out for associated disease. We all know that endometriosis and fibroids are first cousins, so they can be very challenging cases.
And to go back to something you said earlier, because you were mentioning about doing everything at once, checking for endometriosis, but also doing the biopsy of the uterus to rule out endometritis, which is of course different to endometriosis. If we could discuss the sort of the uterine environment in more detail, because again, I know at the ESHRE conference back in July, that's being discussed more. There's better understanding about the uterine microbiome. But for those who may not be familiar, to what extent or degree is that something that you'd investigate at your clinic of importance?
So Jessica,
the questions come through?
Yeah, you're breaking up a bit, but I think I caught your question.
Okay.
Yeah.
Okay.
To be honest, we try to be sensible. In my view, I believe in investigating, but I try to be sensible. So microbiome, for example, is not my first line investigation. Male and female karyotype is, just to give you an example. And if I were to share some of our secrets and protocols, we believe in investigating within reason. So for karyotype analysis, cystic fibrosis, thalassemia is within reason. If you have a couple coming through for IVF for the first time, or a single lady in her mid-30s who's never had a miscarriage or clear history, I think microbiome testing is probably over the top. If for any reason I do a hysteroscopy, an office hysteroscopy, I always check for histology and CD138 endometritis, because these are simple, inexpensive tests that may give us a lot of answers. I keep microbiome testing and NK cell testing of the endometrium, and PCR, advanced microbiome testing, if there is an indication, if there's implantation failures, miscarriages, very thin endometrium, endometrium unresponsive to estrogen, and so forth. And another little
absolutely
trick of the trade, in order to bypass this small chance of microbiome imbalances in low-risk patients, I generally tend to promote probiotic treatment as a whole to everyone. So anyone who's going through IVF, I like to recommend probiotic treatment, just to ensure that we protect somehow the uterine balance without over-treating, of course, with antibiotics and other means.
Absolutely, because of course the antibiotics can hugely interfere with that. They may be necessary if there's an infection, but problematic if you're not going in afterwards with the probiotics. And I totally agree as well with what you were saying about not having a first line testing. I suppose I'm coming from a place where I tend to see cases which are pretty complex and have already done the karyotyping, tried many other things, and they haven't got answers. So that's why I was mentioning that area. And if someone has done those checks and you feel that everything has been covered, what would be the next steps that you'd recommend to someone, like you said, perhaps the more complex cases, who maybe feel that they have ticked those boxes, but they aren't getting anywhere?
Sure. I think I would go a little bit deeper in investigating, because as far as I'm concerned, I believe there's 4 factors: male, female hormonal, ovaries, and the hormonal status, and then the anatomy. I need to be sure that the anatomy is normal. I see very often missed hydrosalpinges, which can be detrimental for success. There's this amazing couple from the Northeast, more than 10 years ago, who had hydrosalpinges undiagnosed. We diagnosed those, removed them, they had 2 beautiful babies. That's it. Hydrosalpinge can be more common than we think, because what we classify as unexplained infertility is not quite that, and sometimes it can be more severe than that. So I want to be sure that the environment is right, and so very advanced diagnosis of the anatomy, and also lifestyle changes, also very important. We all know too well that the association between adverse factors associated with either low BMI or high BMI. I don't think we should rush our patients. We should be rushing our patients for IVF. I think we need to optimize that. 2 months, 3 months may make a huge difference. And of course, the male factor. We have been neglecting
men. That's
what
I was waiting for.
Just because we can pick out the best sperm and we can produce beautiful embryos in the lab, it doesn't mean that this embryo will be successful if, for example, there's missing double strands of the DNA, or if there's any infective factors, or if there's any karyotype anomalies that we haven't picked up. So I think we have neglected men. I also believe that sperm quality is the absolute gold standard test for the general male health. We should be forgetting that. A 35-year-old with low sperm count is not only subfertile, but he's also potentially ill.
What's going on? Absolutely.
We should be addressing that. Perhaps the longevity of that person is probably smaller by 10 years and so forth, and we should be addressing that. If you ask me, what is the one and only medical checkup for a male that would mirror the male's health condition, I would say semen analysis. Whereas people think that semen analysis is only for fertility. That's not the case. So men, yes, standard tests. In our standard investigation is semen analysis, full culture, and DNA fragmentation index. Up until a few years ago, we thought that, it doesn't matter. It doesn't matter for ICSI because we do ICSI. But it does matter. Now we know that very well. We know, and interestingly, it can be treated very easily. Lifestyle changes and the vitamins.
Yes, and obviously the anatomical side, varicocele or infections and everything as well, ruling out, because the male factor is something that I would focus on a lot with clients. And I'm just thinking of a couple I was speaking to last week. And exactly as you said, he felt very frustrated, very angry that his side had really been overlooked. They had tried requesting previously the sperm DNA fragmentation testing and were dismissed, and then subsequently found out that it was a big issue, very, very elevated, one of the highest I'd seen. So if we could bring that into the conversation more, the way you described that, I think, is actually a wonderful marketing line that should be used, which is that if it was explained to men that way, that, your semen analysis and indeed the DNA frag can be a reflection of your overall health, maybe there'd be more of this conversation happening, and there'd be more of an impetus, because they'd understand that, well, yes, if there's problems on that side, there could be low testosterone, which obviously is going to mean problems for the male and problems with his overall endocrine function. Or indeed a case I had last year, who they found the elevated sperm DNA frag, and as part of their investigations with the urologist, ultimately discovered testicular cancer, which he had no symptoms of. So I just think, it's a hugely important area, which I hope will continue to evolve and be discussed more thoroughly. So to anyone watching, if that hasn't been looked at, if the male partner, if your conceiving partner has been ignored, yeah, please make sure to discuss that in more detail. And so in terms of, the advice that you'd have for people who are on this road, I know that many people would ask me, what are the best questions to ask the fertility clinic? What should I be looking out for? Because it's so confusing for people. There's so much choice and sparkling websites that they're looking at that makes it very difficult. So what would be the red flags that you would say to people to watch out for, and what kind of level of care they should expect?
Okay, to be diplomatic here.
Yeah.
For me, I get asked many times, how the hell do you get the results? I mean, I have to say that, I have to be clear, most of our patients are referred by fertility doctors, fertility midwives, fertility coaches, people in the fertility world. So, and of course, I get asked many times, and I get asked, how do we manage that? And I like to be transparent into explaining. It's not easy to just say, because it happens. I mean, one red flag is how many days per week is the clinic open? So I'm aware of clinics, for example, doing egg collections Monday, Wednesday, Friday. I'm aware. I have worked in such clinics in the past. I am aware of clinics who never do pick up Saturday or Monday, and they never do pick up on Tuesday, because then the blastocyst would be on a Sunday, and of course they never do that. So I think one red flag would be, how many days a week do you operate? Is it 7 days, or is it 4 days? Number two, so how to pick a perhaps a good clinic. So one, how many days do you operate? Number two, how many members of staff for how many cycles? I think that's an easy question. So it's very easy to divide. So you would hear 30 members of staff for 1,000 cycles. I think that's not fair. That's
They're trying to cram too much in.
Number three, of course, how many embryologists for how many cycles? Number four, you have embryologists in the lab or lab technicians. There's some amazing units, very, very big, very famous, very well known, and they have technicians doing just ICSI, which could be fine, but I can challenge that versus a senior embryologist of 10+ years experience at the moment. Perhaps when the robots come in, it may be easier. What is the level of the gynecologists? What are they? Are they fellows? Are they trainees? Are they newly qualified? Are they in training? Are they junior consultants, senior consultant, and all that? That is also, who is going to be treating me. So I think these are undisputed factors for quality, I have to say.
That's a brilliant list. And with regard then to the level of communication from the clinic, I find a lot of people complaining about just feeling cared for. One person recently put the question this way. She said, Jessica, is there any point looking for a clinic that will actually offer me some compassion as I go through this process, or are they all just the same? Are they all clinical and cold? Which I obviously said, no, they're not all the same. So that aspect, I suppose, the human element in what is obviously a very clinical process, how do you view that as being best managed?
Well, I think it has to be, again, maths. A clinic with 30, 40 members of staff that does 1,000 cycles, they can never have the level of care because there's no time, especially if they're cramming the patients in 3 or 4 days a week. So, some people, they want more. Some people, they want the impersonal. They see it a little bit more technical. So, like everything in life, I think my suggestion to patients is see what suits you. And, some people are a little bit more technical. Some others, they require a little bit more care. In our practice, we have amazing medical assistants and midwives. So each patient is allocated a team of 3. So one doctor, one midwife, one medical assistant. So so that they can communicate. And of course, we all know that people hesitate to email the doctor, but the medical assistant, they can be closer to, and similar to the midwife. So working with small teams, and we ensure that each team, they don't manage more than 10 patients a month, just to give you the level.
Right. Yeah, that makes sense.
Of course, this doesn't make any business sense to many people, but as I said, that different people work in a different way. Sometimes it's better to have a small waiting list, or it's better to say that, you know, we're having 2 months off in August, than cutting corners in quality and also in providing care when the patients need them. We can always manipulate the patients, manipulate the cycles in terms of medicating, pre-medicating, so that egg collection doesn't happen on a weekend or on a bank holiday. But to be honest, we never do that. But I'm not sure this is for the benefit of the patients.
Absolutely. Those are all very sound points, because I think on this journey, that's one of the most difficult things. See, people report back that it isn't just the problem with getting and staying pregnant. It's all the stuff surrounding that you have to deal with that is just a huge headache for people. So anything that can make it a little bit more bearable, and having sufficient care, enough information so they can make informed decisions, you know, should be standard care, but unfortunately it's not all the same everywhere. So I just want to jump to the questions that we have just before winding up this evening. The first one that jumped in near the start when we were talking about PRP is, I'll pop it up here so you can see it. What about exosomes and bone marrow stem cells? So this is back to the theme of, you know, what can support ovarian function and egg quality, because there's lots of new research. So what's your take on that?
Sure, Gemma, thank you very much. So exosomes is the next big thing after PRP, and in particular autologous exosomes. So exosomes produced by the patient's own body, body fluids, blood or urine. My department, my unit, we are now in the process of developing protocols for autologous exosome production. We're discussing with some amazing scientists from all over the world. And hopefully in the beginning of next year, we should be able to be offering this either alone or in combination with PRP, or combined with activated PRP with the use of hyaluronic acid, cellulose, and perhaps collagen. So yeah, exosome definitely, I think, is the future. Now, stem cells, there's a lot of guard on that. As far as I'm aware, it is not really allowed, at least in Europe, outside clinical trials and experimental work and all that. There's a lot of reservation, to be honest. I think it's going to be many years before it may become available. We're not planning to use it. I think there's a lot of safety and quality concerns that make it strictly experimental at the moment. But exosomes is coming.
And with the exosomes, when you're talking there, do you feel it's of most benefit to the ovarian function, or just because you talked about combining with hyaluronic acid, etc.? So were you talking about endometrial function as well, or more the ovaries?
Yeah, both. But I think probably the key advantage would probably be in the ovaries.
Yes. Okay. So lots to look forward to in the research there. I look forward to seeing more on that. And the other question here, I'll just pop this up. Do you have counselling as standard for each patient? That's a great question. I was thinking that myself when you were talking about the patient coordinators.
Yes, the fertility midwives are in charge of that, and they offer it invariably to every single patient, yes.
Okay, that's good to hear. And then the last one here that have been posted, vitamins for DNA frag and poor motility. What would your recommendations be on that?
Depends on the degree of DFI abnormality. Depends on some parameters. Invariably, we may also perform oxidative stress tests on that patient if the DFI is really abnormal. And then we do some vitamin level tests in the blood. Yes. And we address the lifestyle factors, and then we usually make a specific combination for each patient. I mean, I know there's a lot of commercially available vitamins, So that's the easy off the shelf, but invariably we don't really rely just on that, and we dig a little bit deeper, because in our clinic we have a well woman clinic and a well man clinic also department. So we dig deeper into the vitamins, into the type of vitamins, into the methylation status of each patient. So it's a little bit more complex than that. I mean, I think that would be a perfect topic for another webinar, Jessica.
I'm delighted to hear that, because I'm tired of generic fertility formulas. I mean, the amount of people I've seen over the years who've taken X, Y, or Z, fertility for men, fertility for women, and they come to me saying, you know, supplements don't work, Jessica. I'm like, well, if they're not tailored to you, they probably don't. And if there isn't proper testing and discussion of your diet and lifestyle and your blood work, I think that makes a lot of sense why people aren't seeing results.
And they may probably, if I may add, Jessica, they may harm as well. And
yes, I was just going to say that. Yes, yes.
There couldn't be a better example than the methylation campaign over the last 10, 15 years. Simply just to feed our patients in, our viewers here, is that since there was a link between neural tube defects and folic acid deficiency, many governments, I'm not exactly sure about the UK, but I think the UK also, I don't know about Ireland, but the US definitely, they have fortified cereal, milk with folic acid, which sounded like a brilliant idea 20 years ago, with a small catch that about 40% of us, we cannot convert folic acid into the active form. And then we accumulate folic acid. And this accumulation of folic acid is harmful. Actually, I'm one of them.
Interesting. Because I'm so glad you raised this, right? I've been asked about this a lot. You know, I had a very tough case probably like 12 years ago, which is what really led me to dig deep into methylation and all the work of the different doctors in this field, like Dr. Neil Rawlins and, you know, so many researchers in this area. And I don't understand why it causes such controversy, because, sorry, I hope you can hear me okay. The internet looks a bit funny, because people are being told that, oh, if you don't take folic acid and you're taking methylfolate, you could be causing harm, because the research has only shown benefit for neural tube defect with folic acid, which is not making sense when you consider you have to convert folic acid anyway to have it be useful in the tissues. So how do you, how often do you see that issue with people saying that, oh, but I'm told only take folic acid and not any other methylated forms?
Not very often, and when I do, I simply run an MTHFR test on them. And if MTHFR is normal, then that's fine. I'm not going to argue. But if it's abnormal, then of course I insist on methylfolate. So I think bottom line for the generic vitamins is that it's wrong. That if we dig deeper in the form of the vitamin, in the type of the form of the vitamin, in how we take the vitamin, for example, we all know about the benefits of vitamin D, but how many of us know that it has to be taken with fats? And unless you do that, it's a waste of time and money and effort. So, you know,
I think you're right. I think we're going to need to do a whole separate webinar on this topic, because I would definitely talk about it all night, as it's my key area of interest. So yeah, to anyone, if you're interested in that, we'll definitely get into that in more detail. I just want to rattle through the last couple of questions if we can before we wind up, just so we don't leave anybody out. And so someone asked here, what would be a summary of male fertility testing? Great question.
Oh, yeah, sure. Great question. Depends. I start with semen analysis, culture, and DFI. And together I do some general tests for the general health. That includes thyroid, full thyroid testing, including antibodies, prolactin, testosterone, and also FSH, LH, estradiol, together with vitamin D and glycosylated hemoglobin. And then based on the history, I may do some liver function tests. So I try to see the man as a whole. Of course, I know the BMI and the blood pressure.
Yeah.
And that's it. Now, if it comes back normal, then I leave it at that. If there's anything abnormal, then I dig deeper. Now, before IVF and before IUI, I strongly suggest genetic testing, karyotype, cystic fibrosis, and thalassemia testing. Thalassemia, most people believe it's only running in the south of Europe, in Italy, in Greece, Portugal, Spain, Malta. It's not true, because with immigration and the mixing of population, we have found thalassemia traits in England, in Ireland, in Scotland, in Germany, everywhere. It's a very inexpensive, simple test. I think everyone should be having it. Of course, in the Asian African population is even more prevalent, and it's once in a lifetime. So I would do that. I would do the blood group on the men, and also the viral screen. So these are the standard male tests. Now, if DFI is abnormal, I invariably suggest the oxidative stress test. And then together with andrologists, I may request some scanning, like Jessica said, for varicocele, for prostate. We diagnose one testicular cancer every month.
Wow.
Yeah.
Wow, that just goes to show.
I don't want to scare anyone. We diagnose one testicular cancer and one breast cancer every month. In the female investigations, no one goes to IVF or even ovulation induction without having had formal breast assessment.
Yeah. People have asked me about that, and it's so important because, of course, if you have an estrogen responsive cancer, you don't want to be messing with hormones without knowing what your risk is. And it's amazing how many people are surprised by that.
This is the reason why IVF got a bad name, because it probably sparked breast cancer, ignited breast cancer when it was pre-existing, and it was like throwing oil to the fire.
Yes, absolutely. And sorry, I'm going to jump to the last couple, if I may, just before we wind up. This person asked, does your clinic have expertise with diminished ovarian reserve or poor responders? I think it sounds like it does.
Yeah, we do. We do. Of course, the definition varies because, for example, a 42-year-old who produces 2 eggs is not a poor responder, is a normal responder. So yes, we do have experience. We try to address the underlying factors. We try to, I have to say that we were amongst the first in the world who studied the AMH hormone, and our papers have been awarded by the Royal College of Gynecologists, and also they're part of the ESHRE guidelines. We do have an interest there. I think there's a lot of ways to work on that. Firstly, we need to diagnose it correctly. And secondly, with lifestyle changes, with vitamins, with the correct protocol. I don't like big stimulations. I don't like 450 units. I never use 450 units to stimulate. I believe in sensible stimulation. I don't like natural cycles either very much, especially if I can, with mild stimulation, produce 2 eggs, 3 eggs. We try to be sensible, and we try to set the scene. For example, IVF for a poor responder is a basket of treatments. Perhaps 3 to 6 months, we ask our patients to dedicate time and effort. Perhaps alternating stimulation between mild stimulation and natural cycles, collecting some eggs. If the woman is over 38, 39, with multiple failures, or over 40, PGTA, to ensure they're genetically normal. We fight for own eggs. I mean, there's another question from Emma, if we would use own eggs for a 44-year-old. Of course, is the answer, of course. We don't give up on your eggs as long as there's a sensible expectation. So you have an FSH of under 20, you have a cycle, if not every month, regular cycle. Never mind if it's a short cycle. We try DHEA, we try lifestyle changes, specific vitamins, acupuncture, full support, natural cycles. If you're ovulating at 44, there may be a competent egg. We've had pregnancy at 44, 45. Now we have a 46 plus year old lady after PRP who produced 5 blastocysts. So we're waiting for that amazing lady from Serbia to have the PGTA result.
Oh, fingers crossed for her.
Evidence shows that if a 44, 45-year-old has a genetically euploid blastocyst, the chance of implantation equals a 35, 36-year-old with untested embryo. So, yeah, we fight for your eggs.
Yeah, which is wonderful to hear. That's a very hopeful note, I think, because I know, forgive me that we can't get to all the questions. I know somebody was asking about that. Would you work with someone age 44 who doesn't or can't move to donor? And I think that's definitely the kind of ethos that I have seen from those who've gone to Greek clinics. And it's really important for people to hear that they will receive that individualized care, and that it's not a case of just treating you based on your date of birth, which so often I see being the case, particularly over in Ireland, UK, but rather, exactly as you said, well, what are the facts? You know, what is your body saying? What are your levels of AMH and FSH and LH? What is your ovarian reserve? How are you responding to the protocol that we put you on? And I think that's key. That's all anybody wants, is just a fair chance. So on that note, because I appreciate we've taken so much of your valuable time, are there any last parting words of encouragement or wisdom that you'd like to give people who are on this journey and are maybe struggling?
Sure. I would like to thank everyone. Thank you, Jessica, for hosting this webinar. Thank you to the amazing people I can read their names off. Lots of love to Fiona. Good luck, Fiona. And thank you for inspiring us, everyone. Every single day, I feel stronger than yesterday, not weaker, not older, younger and stronger, because I get inspired by the most amazing people. And I feel very, very privileged to have been in this place.
That's beautifully put. Thank you so much, Dr. Tsakos, and thank you to, like I said, my IVF and European Fertility Society for making this possible, because all of these discussions and webinars, as you can see, are completely free and are there to support you when you need it most. So please do let us know, give us your feedback of what you thought about the event, and if there's anything else you'd like us to cover in future. For now, we'll sign off. But thank you so much for everyone who attended, and I look forward to speaking to you again in the future.
Thank you.
Take care.
Bye.
Bye-bye.